Assalamualaikum warahmatullahi wabarakatuh. So shall we start now? So today's topic, sorry, can I just check after this session, will we have another session after this, or we only have one session today?
We only have one session.
Sorry, only one, eh? Okay, good. Now, today's topic is leukemia and lymphoma, but I'm probably going to approach this as a session to briefly discuss about all the main hematological malignancy, and hopefully we're going to at least understand the highlights of each kind of malignancy. Yeah. Now let me share a presentation. This is a presentation that I used to teach master student, but we're going to use it as our template as well. So just to take this question first of all, so a 60-year-old man presented with 1 day history of progressive shortness of breath. He had been having fever and lethargy for past 2 weeks, and fever on examination, saturation was slightly low, but not too bad. But there was cervical lymphadenopathy, and liver was palpable, and as well as spleen. And we can see here the hemoglobin 6.5, white cell count of 120, and platelet of 75. So the answer for this question would be hyperviscosity. So the white cell count of 120 that eventually can cause leukostasis and also hyperviscosity. Now the first main hematological malignancy, then we have quite a few patients in the hospital at the moment in IM3 with acute lymphoblastic leukemia. As we all understand, there are two main ways of classifying leukemia. One is whether it's acute or chronic, or based on their cell origin, either it's lymphoid or myeloid. So the first malignancy that I'm going to discuss is acute lymphoblastic leukemia, and they can present with a very high white cell count or pancytopenia, and we have a very good example in IM3 at the moment. Whoever has the opportunity to look into the case, one patient presented with white cell count of more than 50. Another patient came just with pancytopenia. Another patient came with a very big parotid swelling. So all of that, a possible way of uh, possible presentation for them. And having white cell count on its own carries a poorer prognosis. So acute lymphoblastic leukemia, as the name suggests, is acute. So the presentation will be within weeks to months rather than years. For example, we have a patient who has symptoms of reduced effort tolerance for 1 month before the actual diagnosis, as compared to a patient who has a chronic lymphocytic leukemia, which I have been following up for 1 or 2 years. They tend to be a bit more asymptomatic. If they have some symptoms, they tend to have it for quite a while. And as we all know, acute lymphoblastic leukemia is fast growing, and if left untreated, patient can die from it. If we look into the image that I shared here. So this is example of acute lymphoblastic leukemia. To be more specific, this is L3. So there are three main types of acute lymphoblastic leukemia. One is L1, L2, and L3. One normally is small, L2 is medium size, and L3 will be big. And L3, be more specific, is basically Burkitt's leukemia, and this is the example that we have to illustrate Burkitt's leukemia. And for the last 5 years working in SASMEC, we have seen one Burkitt's leukemia who died, and another one appeared to be something similar to Burkitt's leukemia, eventually die as well. So it can be morphologically um, classified based on their size and their appearance using the FAB, French American and British classification, or it can be diagnosed as well by using a bit more specific way, which is immunophenotyping. And based on immunophenotyping, we can recognize the cell to be whether this is blast cell, whether this is very young, immature blasts, and we can also identify them either it's B or T cell, as we all know lymphoid can be either B or T cell. And at the moment, all the three patients that we have in IM Tiga, they are all apa nama dia BALL. Okay. Um, so this is the way of diagnosing them. So using cytomorphology, i.e. looking at the appearance, I mentioned earlier using FAB classification, L1, L2, or L3. Or we can do immunophenotyping, recognizing the cell differentiation protein on the membrane of the cell. And another thing that we need to understand whenever we diagnose cancer, one is diagnose, another part of the diagnosis is to classify them, to prognosticate them, whether this is very uh, high risk of relapse or a low risk of relapse. And if we discuss specifically in ALL, based on the protocol that we use, they have certain ways of classifying them. For example, if we use BFM 95 protocol that we are using at the moment, normally for young patients, they base among the thing that we look into the risk factor is whether the patient has BCR-ABL positive or 922 translocation, or another translocation called 411 can also carries a poor prognosis. Apart from that, we also look into um, whether this is B or T cell. So at least T cell will be a moderate risk. Yeah? And if the patient responds to the medication that we give within the first week of treatment, that also carries a good prognosis as compared to patient who remain to have the same disease in a week. So one is to make a diagnosis, another one to identify the risk factor, i.e. whether this is not a risk factor to cause ALL, but risk factor means you identify this is a high risk of disease relapse or low risk of disease relapse. Another thing we look into is identification of therapy targets. So I think we discussed earlier about chemotherapy, cancer treatment. We also have a very specific uh, agent that we use to target specific mutation or specific protein. For example, your CD20, you can use rituximab, or you have bilinotumomab, which is the bispecific antibody, or we can use tyrosine kinase inhibitor like imatinib for those having positive PCR-ABL. Okay. So you can always interrupt me if you want to ask any question. Earlier I mentioned about immunophenotyping. So immunophenotyping is identifying the the, what you call this, the cell differentiation protein. So this is a few example. You can have HLA-DR, or TDT positive, CD19 positive, and so on. Yeah, and we do it we do it locally. We do it in Sasnag. Earlier I mentioned about prognostication. This is a very general reference that we can use to look whether this is a poor prognosis or high risk disease. But we can also base on the protocol that we use, because the protocol was run based on certain criteria before they got established. So we can use that as also a reference. So mainly patient who has ALL has a good prognosis. Again, very much depends on whether they achieve a good remission, what we call MRD. So I don't want to go detail about this. It's very much a post-grad discussion. Now, any question about ALL? So ALL treatment is chemotherapy. ALL treatment has evolved quite a bit, from a very aggressive intensive chemotherapy to a very prolonged and what we call it rationalized chemotherapy, which are given in different phases. For example, the first 2 months of treatment, we only give the chemotherapy once a week, roughly, before we get into more intensified phases. After that, so it's a long treatment, can go up to a year and a half. And for those patients who are deemed to be high risk, we're going to offer them to undergo allogeneic stem cell transplant to secure a better prognosis and secure lower risk of disease relapse. Okay, any questions about ALL? The question. Okay, so next we want to use another example. Is 56-year-old man presented with easy bruising, tiredness for 1 month, white cell count of 102, platelet 850, and hemoglobin of 11. The blood film reveals neutrophilia, basophilia, and numerous myelocyte and 3% myeloblasts. So the diagnosis for this case is chronic myeloid leukemia. So what is the key point from this question? First is normally with CML, they tend to have, kita panggil panmyelosis, rather than one single cell line proliferate, the whole myeloid series will be raised. For example, the neutrophil will be raised, the basophil will be raised, and all the precursor of neutrophil will be part of it, will also raise. And we need to make sure also the myeloblasts or the immature cells are not raised, because once they reach to more than 20%, especially, then they become acute myeloid leukemia. For CML, is very much all this myeloid cell line will be raised, and that will include your platelet as well. So the CML is hyperleukocytosis. Remember, all the cell line will be increased. They can get splenomegaly as well, and normally it will be described as massive splenomegaly. Recently, we have diagnosed a patient who has CML, but unfortunately transformed to acute myeloid leukemia, as we can see based on these CML phases. So it can be a chronic myeloid leukemia in chronic phase, or it can progress into accelerated phase or even blast phase. Very much depends on the patient's blast number appear in the blood film or in the bone marrow. So that particular patient presented to us with diagnosis of CML, with a spleen size down to the iliac bone, but because of the blast count more than 20%, then we diagnosed it to be acute myeloid leukemia. But it's very much a evolution of the CML going to AML because of treatment, no treatment given to the patient for quite a while. The key point about diagnosing CML is looking at the current, looking at the translocation 922 by using karyotyping. So we can identify the Philadelphia chromosome, or we can do a FISH or cytogenetic test called fluorescent in situ hybridization to identify the the 922 translocation. Or we can also do molecular tests looking at BCR-ABL1 gene. For that patient, we identify the genetic mutation using molecular to start with, and followed by karyotype or by FISH. The main key treatment for CML is tyrosine kinase inhibitor, and it is the first disease that can be treated by using tyrosine kinase inhibitor. The first medication that still exists now is imatinib, which has now there are more lines of treatment, either second or third generation tyrosine kinase inhibitor. Furthermore, we have even newer drugs, which is not widely available. But to mention that, because CML is a very treatable disease, we may not be able to claim cure at the moment, but I think eventually down the line, it can reach to that state. Previously, CML is a death sentence, and the only way to treat CML by using endogenous stem cell transplant, but it's not anymore. And the life expectancy of CML is as long as a normal person, as long as we treat the patient with appropriate treatment. Eroka? Oh, Kamara. Okay. Okay, so Kevin. Boleh? Ada ke Kevin? So it's as good as a normal person as long as we can treat them using appropriate TKI. Yeah. And it has improved significantly over years. Yeah. So this is a translocation I mentioned, the Philadelphia chromosome, and that lead to BCR-ABL gene. Okay, you can have this presentation later on. So next question is, a 42-year-old man presented with tiredness, breathlessness, and epistaxis last 3 weeks, noted to have easy bruising, both arms and legs, hemoglobin 7, white cell count 13.8, platelet 24, myeloblast of 21%. So the key point of this condition is there is blast cell appearing on the blood film with significant number 21%. So this is a diagnosis of acute myeloid leukemia, and how to diagnose them, we need to do bone marrow. But to prognosticate them, we need to look at the cytogenetics. Yeah. So acute myeloid leukemia, again, is acute, and it involves the myeloid series. Um, and the way we diagnose them is once the number of blast cell appear to be more than 20% in the bone marrow, then we can label them to have acute myeloid leukemia. For acute lymphoblastic leukemia is 10%, yeah, of blast in the bone marrow. So that's the normal way of diagnosing AML, but there are certain condition or certain type of AML that are very much specific, is a very specific disease which are caused by certain translocation. So we give one example here is 821, but more unique AML is APML, acute promyelocytic leukemia, which the one that always been described to cause the IVC, and that is associated with translocation 1517 with the MLRRA gene. Yeah. So the main AML will be diagnosed by flow cytometry or immunophenotyping. Um, but certain AML have very specific genetic mutation will be diagnosed by either cytogenetics or molecular tests. So AML is very non-specific presentation. You can either signs or symptom of anemia, thrombocytopenia, leukemia. It can also be a bit more dangerous, like the IVC in APML. Okay. We used to refer to FAB as we did for ALL, French American British classification, but not anymore. We now based on WHO categories. Um, we try as much as possible to try to characterize them using a specific translocation. So it's very important now to have the facility to do cytogenetics or molecular tests, because that will give a very specific diagnosis and predict the response to treatment better. And currently in hospital UIA, we can do karyotyping, we can do molecular tests for MPN1 and FLT3 and so on. So we have a bit more facility to diagnose and characterize them now. Yeah. Just a brief summary on this slide. APML cause DIVC. We diagnose them when they have more than 20% of blasts. We can use immunophenotyping to diagnose. For some condition, we need to use cytogenetics or molecular tests. And again, as ALL, we also need to stratify them based on the genetic mutation. For example, we have here favorable, intermediate, and adverse. So all the patients who been diagnosed with acute myeloid leukemia, they will have all the tests done. And at the moment, we have one patient with acute myeloid leukemia, to be more specific, acute promyelocytic leukemia, a young 12-year-old. We diagnose it by using molecular tests to identify the PMRR. Later, we wait for the cytogenetics or the karyotype, whether we can see the 1517 translocation. So the boy in IM3 should have a good prognosis. So the gambar at the top on the right ni adalah is our rods, yeah. So cell for APML ni will be big, and they have a lot of granules within it, what we call our rods. But the patient that we have at the moment in IM3 is not the typical APML, but is the hypogranular variant of APML. So he doesn't have all these rods. So that's AML. So treatment for AML is chemotherapy. So we induce them with DA or a combination of anthracycline and arabinocytarabine. normally 3 plus 7, i.e. 3 of anthracycline and 7 of cytarabine. We repeat the process until we get induction, normally 1 or 2 cycle, and then followed by consolidation. Whoever are adverse or intermediate risk, then we offer them to do allogeneic stem cell transplant. So the next question. "60-year-old man presented with rheumatoid tolerance, 6 months. There was no fever, no significant family medical history. Appear was pale, but hemoglobin was only 10, MCV of 108, white cell count of 25, and reticulocyte was raised at 6.4. So this is a bit complicated case. Diagnosis is chronic lymphocytic leukemia. I'm probably not going to explain how to answer this question, but just to highlight that acute lymphocytic leukemia is a chronic disease involving the lymphoid cell, and it can manifest on its own as CLL, causing high white cell count. It can also cause lymphadenopathy, splenomegaly, constitutional symptoms. It can also cause, but majority of them will not have. And they can also present with a autoimmune phenomenon, like in this case where patient having hemolysis. Yeah. So IHA is another way of CLL, another way of CLL manifestation. So it's indolent, i.e. is very slow growing. It can be a leukemic or lymphomatous presentation, i.e. it could be just pure white cell count being high, or you can have pure lymphomatous, i.e. lymph node involvement without any blood, without any circulating CLL cell. In terms of terminology, we use the word CLL, or the term CLL for those having increase in white cell count, lymphocytosis. But for those without lymphocytosis, and we find the leukemic cell in the lymph node, we call it small lymphocytic lymphoma. Even though it named as lymphoma, it is very much the same biology as CLL, and it should be treated the same way as well. So diagnosis is flow cytometry, especially those having leukemic presentation. And we also need to prognosticate them. More specifically, there's one particular genetic mutation which are deemed to be having poor prognosis, which is 17p deletion. We have a different way of staging them. Remember, in ALL, AML, CML, we don't really have a staging system. But in CLL, we stage them based on dry or RAI staging or BNET staging. You can look up later on how to stage them. And we don't normally treat the patient unless they falls into any of this indication for treatment, i.e. doubling time. So if the white cell count increase double within 6 months duration, then we may consider treating them. Or they develop cytopenia, i.e. they can get anemia or significant thrombocytopenia, which warrant treatment. They can also have organomegaly or lymphadenopathy, so big spleen, big liver, significant constitutional symptoms, or they can get autoimmune cytopenia. So these are all the things that we need to consider before treating the patient. So it's very much considered to be a Western Caucasian disease, but I think until recently we have diagnosed quite a bit in SASMAC. We may not really have a good data to say that it is not our disease. I think the more tests that we do, we tend to diagnose more. We mentioned about flow cytometry early on. I'm not going to go detail about it. So we can diagnose them using flow cytometry. I mentioned about it can be a lymph node manifestation, and it will be named as small lymphocytic lymphoma. We prognosticate them based on the Rye and Binet staging, as well as we can use the cytogenetics. Okay, so treatment for CLL is chemotherapy, and there are a broad option of chemotherapy that we can use, a combination of immunotherapy like rituximab and conventional chemotherapy, and we can also use the new BCL2 inhibitor called venetoclax for those who are elderly or has progressed um, based on previous treatment. And we can use also the BTK2 inhibitor, which is ibrutinib as part of treatment. So the option is very wide for treating CLL. Now, next question is a 44-year-old woman with acute myeloid leukemia. So I think this is for brain treatment. So we can skip that. For TLS, we have another session about that. So another malignancy or pre-malignant condition is myeloproliferative neoplasm. We just take this example: 53-year-old man, abnormal finding of hemoglobin of 21.2, hematocrit of 59, white cell count of 10, and platelet of 230. So this patient have erythrocytosis. So investigation that we tend to do to diagnose polycythemia rubra vera is JAK2 mutation. So myeloproliferative neoplasm is a condition, is a family of conditions um, uh, involving either is polycythemia rubra vera or essential thrombocythemia and primary myelofibrosis. And it's driven by a mutation called JAK2 mutation, mainly in polycythemia rubra vera up to 95 to 98%. And the rest of MPN, they have about 50 to 56% of JAK2 mutation. There are other mutation associated with it, but the main one is JAK2 mutation. For polycythemia rubra vera, we diagnose them before we do the JAK2 mutation. We look at the hemoglobin and hematocrit, and then we follow by using a JAK2 mutation. And then I will offer the patient to do bone marrow to complete the investigation and also to assess whether the patient has element of fibrosis. And why is that? Because we know that condition polycythemia vera can also transform to myelofibrosis. So whenever you diagnose polycythemia vera or essential thrombocythemia, you need to look at the condition, whether is it a very early stage or has it slowly transforming into myelofibrosis. And then the treatment will be slightly different and the prognosis will be slightly different as well. And all of this can also transform eventually to acute myeloid leukemia, which carries a very poor prognosis. Okay. So far, any question? I don't want to carry this uh, discussion without having a feedback in case I'm covering too deep or too superficial from your side. Any questions?
Doctor, I have a question. My name is Ashraf. What is the difference between bone marrow transplant and allogeneic stem cell transplant?
Okay. I think we have another session about this, right? But I briefly touch on this. So bone marrow transplant is a broad term to describe replacing the bone marrow. Okay. But more accurately, we probably should be using more is stem cell transplant, because we rarely use a bone marrow material to replace the bone marrow. in certain conditions, yes, we can use the bone marrow itself to replace. For example, in aplastic anemia, mainly aplastic anemia. But in majority of cases, we only use stem cell. So we use stem cell to we get the stem cell from the donor and then we infuse it to the recipient patient. So kita infuse to not to the bone marrow, but we infuse into the peripheral blood, and this stem cell will eventually find his way to go to the bone marrow and reside there. Um, and once it reach to the bone marrow and stay there, we call it grafting, engraftment. So it go there and stay there and proliferate. So the word stem cell transplant is more accurate nowadays, even though there are method that we can use the bone marrow itself. The majority is very much the stem cell that we use. We harvest it by just taking blood, like blood donation, and we separate the blast by using centrifuging, and then we identify the number of blasts or the immature cell, the stem cell, using flow cytometry. Allogeneic and autologous transplant means one is allogeneic, means we are using somebody else bone marrow or stem cell. Autologous, we are using our own stem cell. So why some condition we use allogeneic, why some condition we use our own stem cell? It very much depends on the strategy of the treatment. If we are if the strategy of the treatment is to give chemotherapy alone, i.e. you give chemotherapy at a little dose, when you bagi chemotherapy yang at that dose it can kill the patient, and by hoping with that dose it kills the disease as well. So in that setting, we only need your own stem cell. So the key point of the stem cell is to rescue the patient. So kita seolah macam pukul betul-betul patient and then save them with their own stem cell. That is autologous stem cell. We use it for certain condition. But for allogeneic stem cell transplant, we not only depends on the chemotherapy to kill the disease, but we also depends on the stem cell, the donor stem cell, to be part of our force to kill the disease. So the idea is slightly different. We want to have the what we call effect, graft versus leukemia or lymphoma effect. So it's a bit more complicated than just a renal transplant or liver transplant, because dia ada banyak element to it. So apart from giving chemo and replace the stem cell, we want the stem cell to act upon the disease and kill the disease, because it will susah sikit, because um, tak apalah, I conclude at there. Is that okay? Make sense when I explain to you?
Yes, Doctor. Thank you.
But the punya science behind transplant is slightly a bit more detailed. Okay, any more questions before we move on? Okay. Now, this is a condition, multiple myeloma. 58-year-old man with acute dyspnea, previous history of T6 compression fracture, hemoglobin of 9, platelet of 151, calcium raised 2.60. But if you try to correct that, the calcium level will be much higher. Total protein of that's wrong, bukan 103 but 78. Apa nama dia, raise total protein. Sorry, the globulin should be higher, bukan 48, should be 73. Apa namanya, and then the scan showed PE and also multiple lytic lesion. So this is the diagnosis of multiple myeloma, and how to prognosticate multiple myeloma. We use beta-2 microglobulin. Serum protein electrophoresis is used to diagnose serum immunization is also to diagnose or urine protein electrophoresis. Um, Lactate LDH can be also used to prognosticate, but not as good as beta 2 microglobulin. So if you look at this X-ray, you notice that there is one area of missing ribs. So if you look at on the right side of the lung, there is one ribs missing. Yeah, and that particular ribs has been eaten or replaced by myeloma cells. So the key cells involved in myeloma is plasma cell. So these are all the acentric cell nuclei. Yeah. So you see this, the nucleus are pushed to one side, and you see a pale area next to it, which is the Golgi apparatus, which are involved in protein production. And as we all know, multiple myeloma involve production of paraprotein, thus the Golgi apparatus be more prominent. So the key features of multiple myeloma is CRAB. So C is calcium, R is renal failure, A is anemia, and B is bone fracture or lytic lesion. Yeah. An example of this X-ray, we can see lytic lesion. Yeah. The CRAB is very much description of an organ damage. So if you have multiple myeloma that end up causing organ damage, they have the features of CRAB they call multiple myeloma or symptomatic myeloma. For those patients who has no end organ damage, there's no CRAB, but when we do a bone marrow, we see significant number of plasma cell, i.e. more than 10%. We call it smoldering myeloma, i.e. asymptomatic myeloma. So the myeloma is there, but there's no end organ damage. There's no CRAB. Another term that we use as well to describe plasma cell dyscrasia is MGUS. So monoclonal gammopathy of undetermined significance, where you have uh, presence of paraprotein, but it's the bone marrow did not show enough significant what we call this significant number of plasma cell to diagnose multiple myeloma. The way how to diagnose multiple myeloma is first you need to have plasma cell more than 10% in the bone marrow, or you can see a plasma cell in significant amount as a plasmacytoma. What is plasmacytoma? You see plasma cell outside the bone marrow. So if you have a collection of plasma cell outside the bone marrow, and that is enough to diagnose multiple myeloma as well. And you need to have with that what you call this CRAB. So multiple myeloma, symptomatic multiple myeloma must have CRAB. To prognosticate them, we use beta 2 microglobulin and albumin level. Okay, and how to treat the patient? Is a combination treatment by using proteasome inhibitor, immunomodulator, and steroid. And there are many more treatment into it. For example, we have CD38 monoclonal antibody called daratumumab. As we all know, plasma cell is a CD38, CD138, and CD56 positive. We have quite a few patients with multiple myeloma in SASMAC at the moment. Majority of them are in the second line treatment. So multiple myeloma is not a curable disease. So whenever we treat them, they always come back with relapse of disease. So I have patient now already going into the third line chemotherapy to treat the patient, to treat the multiple myeloma. So you can, if you have time, you can go to the daycare and probably meet them, have a chat on how they present with the diagnosis of multiple myeloma. Some of them present with bone fracture. Some of them present with anemia, only anemia. Some of them present with renal failure requiring dialysis. Some of them present against with relapse and spinal cord compression. So it's very devastating disease if left untreated. So next question is about Hodgkin lymphoma. So I'm probably not going to go there. So Hodgkin lymphoma. So now I'm going to go to lymphoma. So the main two type of lymphoma is Hodgkin lymphoma and non-Hodgkin lymphoma. The main big difference is one has red stem cell and another one doesn't have red stem cell. But Hodgkin lymphoma normally they present with lymphadenopathy and B symptoms, and the B symptoms originated from Hodgkin lymphoma. We use it to describe either symptom of either condition, but it's mainly described to be part of prognostication only in Hodgkin lymphoma. So the diagnosis of Hodgkin lymphoma, we need to have that red stem cell to be positive in the sample that we take, the lymph node biopsy, and they normally to be positive in CD30, PAX5 as well. And there are two types of Hodgkin lymphoma. One is the classical Hodgkin and another one is non-classical Hodgkin. We have one non-classical Hodgkin that we have treated in this hospital, which is not that common. The majority of them will be classical Hodgkin lymphoma. We use PET scan. I think I described earlier the role of PET scan in monitoring the disease. It's very chemosensitive, so it used to be treated using radiotherapy, but nowadays we are using chemotherapy. And how to stage Hodgkin lymphoma, we use an Albert staging. The treatment you can see down there, ABBD, escalated Birkhoff, and we also incorporate irradiation if needed. So this is example of an X-ray of a mediastinal mass. Normally, young adults be most affected. Okay, and they can be divided into classical and non-classical. Remember, Hodgkin lymphoma is not a disease that one cell proliferate to form a mass, but rather is a conglomerate of many types of cells in the mixture. So apart from red stem cell, you also have the lymphocyte, eosinophil, fibrosis that occur around it. Thus, we can classify them into the four main types, whether this is the nodular sclerosing, lymphocyte rich, lymphocyte depleted, or satu lagi anaplastic, Hodgkin lymphoma. So remember the Ann Arbor staging. This is a very old diagram that we can look at, but if the Ann Arbor staging is used to describe whether the disease is at one area, two areas, does it cross the diaphragm? Is it only one side, so only above or below, or does it involve outside the lymphatic system? Yeah. So next group is non-Hodgkin lymphoma. Is a very big family of non-Hodgkin lymphoma. So there's no way that we can cover it within this short period of time. But we can classify them either as B or T, aggressive, high grade, or low grade. The main way of diagnosing is by doing a core biopsy, and some conditions require cytogenetics. For example, your Burkitt's lymphoma is 814, your follicular lymphoma is 1418, your mantle cell lymphoma is 1114. So certain type of lymphoma have a very specific genetic mutation. So the backbone of non-Hodgkin lymphoma is R-CHOP. It may change a bit in terms of its regime, adding in something or reducing in something, but the backbone is R-CHOP. Yeah? There are ways to prognosticate them using different calculation based on the diagnosis. Okay, I think that's about it really. Any questions? Lain ni macam TTP, we can cover it some other day. Any questions about lymphoma?
Assalamualaikum, Doctor.
Assalamualaikum.
My name is Uzma. I want to ask for lymphoma. Is it a fast-growing like condition, or does it take a long time? And also, I want to ask about the prognosis.
Now, lymphoma, as I mentioned earlier, it can be subdivided. So the way to classify things either based on their origin or based on the way it behaves. So origin is B or T cell, or is it follicular or germinal center, but there's very much a histological or based on the biopsy that we do. Now, the way looking at it is whether it's very fast growing or slow growing. So there are two types of lymphoma, whether it's fast or slow growing. The aggressive one would be something like Burkitt's lymphoma, double hit lymphoma. The more common one is diffuse large B cell lymphoma, which is the majority of non-Hodgkin lymphoma. It is fast growing. It can be as fast as every 6 hours it multiplies. So whenever I diagnose patient with non-Hodgkin lymphoma, especially diffuse large B-cell lymphoma or anything that is more aggressive than that, I will not delay it, until 2 months or 3 months. So bear in mind when you work as a doctor, you can trap into this routine way of doing things. You biopsy something, you follow up 3 months after because malas nak jumpa. Unfortunately, this thing will grow as quick as it wants. So we need to chase the result as quickly as possible, either phoning the lab to know it, to have a provisional diagnosis to start with, to plan to see the patient sooner. So whenever I diagnose patient, at least I give them at least a week. I cannot delay longer than that. So indeed, they are fast growing that we need to treat early as possible. And we look at the behavior of the disease as well. We look at the proliferation index, i.e. the Chi-67 immunohistochemistry provided by the histopathologist. The slow growing disease like follicular lymphoma, marginal zone lymphoma, majority of them will not require any treatment. The approach that we tend to do is if we diagnose them, unless they are symptomatic, we just monitor them regularly in clinics. We see them every 3 to 6 months to see if there are any indication to treat, either they develop symptoms or cause any severe cytopenia and so on. So there are two types. One is slow and one is fast. Now, how to prognosticate them? I just listed down a few calculation that we can refer to. A majority of the score that we use will involve stage of the disease, whether we adopt the same Ann Arbor stage for non-Hodgkin lymphoma as well, same as Hodgkin lymphoma. And the higher the stage patient presented with, the lower prognosis, poorer prognosis it is. But apart from that, we look also at the age of the patient, the ECOG status, the performance status, and we also look at the LDH, some of them, and any involvement of extramedullary or extra lymphatic area. So it's very different one to another kind of lymphoma. So in general, we look at the disease profile as well as the patient's profile. As I mentioned earlier in the previous common lecture, to treat the patient, we need to know the patient as well as know the disease. Okay. Is that clear?
Yeah. Okay, thank you.
Any more questions? Okay, kalau tak ada question, I will share this presentation to the group leader. I think I have not shared the previous common lecture. Whoever the group leader just approach me and then I'll share it to him, both of the presentation. Okay. So if there's no more question, we end there. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.